Hi, I'm Peter Anglin from South Lake and Newmarket. I'd like to welcome you to the panel discussion of CLL following Dr. Mato's talk, which was very comprehensive. We're fortunate to have Dr. Graeme Fraser from McMaster with us today. Graeme's going to talk about Canadian context and the CLL data. So with no further ado, I'll turn you over to Graeme. Graeme, thanks for being with us.
Thanks, Peter, for that introduction, and it's my pleasure to be here to present a Canadian perspective on the data you've just heard presented by Dr. Mato. It really was an excellent talk that he provided, a very good overview, evidence-based and pragmatic discussion, which I think is very relevant for our audience. And so I don't plan to really review a lot of the data again, but to try and really just focus on how that data applies to the Canadian setting. These are my disclosures. So briefly, the approach to the frontline management of therapy in CLL, again, begins with an assessment of whether patients have an indication for treatment. And there's a number of important pieces of information that we require in order to optimize decision-making. In Canada now, there's really quite good access in most institutions now to FISH panels, P53 mutational testing, and mutational status of the immunoglobulin heavy chain gene. These are really the key prognostic markers that will inform treatment decisions. Next, an assessment of patient age, fitness, their comorbidities, and concurrent medications is also important in decision-making, as well as patient preferences. We're now in an era, particularly within novel agents, where time-limited versus indefinite treatment options are increasingly available to us, and patient perspectives on this are important. And lastly, drug availability is relevant, and I'll try to highlight where we are currently and where hopefully over the next 6 to 12 months, we may have access to additional regimens in Canada. So based upon this framework, for patients who have a P53 abnormality, either a mutation or a deletion of 17p, indefinite BTK inhibition really, I think, remains the standard of care. This is an approach that has the longest follow-up of prospective data sets. And there was, I think, an informative abstract presented at ASH in December of a pooled assessment from 4 trials of patients treated with ibrutinib in the frontline setting with deletion 17p, demonstrating at 4 years of follow-up almost an 80% progression-free survival. So certainly, I think there's good long-term follow-up, and I think this remains the standard. For patients who are considered fit and young, in many jurisdictions, the mutational status of the immunoglobulin heavy chain gene is helpful in informing our treatment options. For patients who have a mutated status and are therefore considered to be low risk, there's long-term data utilizing frontline FCR immunochemotherapy, showing a majority of patients may enjoy prolonged progression-free survival, even with 10 and more years of follow-up. And so this remains, I think, a valid option for this patient population. The ECOG 1912 data set evaluated ibrutinib plus rituximab versus FCR. And in the overall cohort, there was an improvement in progression-free and overall survival, although in the mutated subset, there was no clear advantage in progression-free survival. There's obviously toxicity differences between FCR and ibrutinib that may be relevant. And so I think ibrutinib is shown in brackets here because it is an option, it's an effective therapy in this population, although I think it's not yet clear how patients will fare with long-term follow-up, and there are differences in toxicity profiles that may be relevant, particularly from a patient perspective. In the unmutated setting, I think it's quite clear that novel agent therapy and again, the ECOG 1912 data really drive decision-making in this population of patients where single agent indefinite ibrutinib therapy is considered the standard of care. In the elderly or less fit population of patients, again, I think it's reasonable to look at treatment options according to the mutational status of the immunoglobulin heavy chain gene. For those that are favorable risk with a mutated status, chlorambucil plus obinutuzumab has been available as the probably most commonly prescribed, I think, immunochemotherapeutic option. Certainly, there are data now available for multiple novel agent approaches. Venetoclax plus obinutuzumab in a 12-month time-limited regimen has been evaluated in the CLL14 trial, and acalabrutinib in the Elevate-TN trial has been evaluated with or without obinutuzumab compared to chlorambucil plus obinutuzumab. And there's data from the Alliance trial with longer-term ibrutinib therapy. Again, I think the challenge here is that for the most part, patients do very well regardless of the treatment options in some of the in these trials evaluating novel agents versus chlorambucil obin or similar chemoimmunotherapeutic regimens in this favorable risk group. There's been similar progression-free survival observed, and so although there may be changes in the Canadian landscape to availability of novel agents in this subgroup, for now, chemoimmunotherapy remains a standard option and most commonly prescribed. In the unmutated population of patients, again, I think we're really moving into an era now much more commonly of novel agent therapy. Ibrutinib is currently available in most jurisdictions, but I think the data from Elevate-TN and CLL14 and the recent favorable reviews through our PCODER process lead to some optimism that we may have access to these regimens in the Canadian setting over the next year. I think there's a lot of interest in the time-limited approach of venetoclax plus obinutuzumab, the venetoclax being typically very well tolerated, and acalabrutinib as a more selective BTK inhibitor, potentially with a more favorable toxicity profile, certainly with some of the off-target toxicities that we see, including some of the cardiovascular toxicities, perhaps being at a lower incidence than ibrutinib. I think there's a lot of interest and the potential for both of these regimens to be available in the Canadian setting soon. In terms of knowledge gaps in this population, in the frontline setting, in the young fit CLL patients with low risk disease, again, I think the challenge here is we lack long-term follow-up with novel agent approaches, and maybe not entirely clear if the long-term outcomes and this concept of functional cure with FCR will be maintained. Obviously, there are toxicity differences which may be favorable that have to be considered. In the high-risk setting, I think the comparison of novel agent approaches have not yet occurred. We don't have data with venetoclax-based approaches, and certainly these assessments are going to be important in some of the currently ongoing, particularly cooperative group randomized trials that are evaluating these approaches even in younger fit patients. In the older, less fit population, so-called FCR ineligible, again, I think our major limitation here in terms of decision-making is the comparison of BTK inhibitor indefinitely versus time-limited venetoclax-based approaches. And I think we're eagerly awaiting some direct comparison data. It'll come first in the relapse refractory setting, but comparing ibrutinib with a more selective BTK inhibitor, acalabrutinib. In the relapse setting, again, I think this was covered extremely well in Dr. Mato's talk. We don't yet have access to frontline venetoclax-based approaches in Canada. And so for the most part, patients in the relapse refractory setting will have been either treated with chemoimmunotherapy in the frontline setting or a BTK inhibitor. And that sort of sets the framework for this slide. For patients who are BTK inhibitor naive, BTK inhibition with ibrutinib, and potentially in the near future, acalabrutinib as an option is certainly very reasonable based upon a number of randomized controlled trials evaluating these agents. And the venetoclax plus rituximab Morano regimen, 2 years of time-limited venetoclax plus rituximab, is also a very reasonable treatment option that is now available in many jurisdictions. I think the decision-making between indefinite BTK inhibition versus VEN-R is currently something that we review, I think, commonly in the clinic, and is often driven by disease biology and patient preferences and patient factors. The very favorable toxicity profile of VEN-R and the time-limited approach, I think, in my experience, has been very attractive for both patients and practitioners, and is increasingly utilized. I do agree that idelalisib plus rituximab probably has a very small niche in the relapsed refractory setting, which would be for the most part after failure of a BTK inhibitor in a venetoclax-based approach. In the BTK failure, patients can either be intolerant or resistant to a BTK inhibitor, and you can see the options are fairly similar in both in both of these settings. There's the option in BTK intolerant population, patients who did not tolerate ibrutinib. There's some data that Dr. Mato reviewed about the potential to switch to a more selective BTK inhibitor, and then certainly a common approach would be to move on to venetoclax-based treatment at such time as patients developed an indication for therapy, with idela plus Ritux and chemoimmunotherapy falling probably further down the treatment algorithm. I think for the sake of time, I'll move past these next 2 slides, which summarize Dr. Mato's approach. Again, I really felt that he provided a very clear perspective on sequencing and management of the novel agents in the relapsed and refractory setting. We still have a gap in terms of knowledge here as well. A comparison of BTK inhibitor therapy versus time-limited venetoclax plus rituximab, that should read. And again, some information about really what the advantages of more selective BTK inhibitor therapy will be in the relapsed refractory setting are likely to be available very soon, and I think very helpful in terms of the clinic. And then looking to the future, I think, again, this was addressed nicely in Dr. Mato's talk. Certainly understanding and overcoming resistance to novel agents is going to be an increasingly important topic, and lots of excitement about agents such as LOXO 305. Randomized controlled trials comparing indefinite BTK inhibitors versus time-limited novel agent combinations are being evaluated in a number of cooperative group studies, both in the US and over in Europe. The German CLL17 trial being a particularly a good example of that, a trial that'll be evaluating ibrutinib monotherapy versus venetoclax or obinutuzumab versus ibrutinib plus venetoclax. And finally, like I said, I think there's some next generation molecules which are very likely to maintain the excellent efficacy seen with our novel agents, but hopefully with improved tolerability. And finally, I think a lot of interest, as was alluded to in Dr. Mato's talk, around the potential role of cell-based therapies in CLL, although I think these currently remain at the level of clinical trial evaluation.
Thanks, Graeme. That was a brilliant review in terms of framing Canadian context. We've got a little bit of time left, and I have about 4 or 5 very specific questions for you. And partly from what I got from Dr. Mato's talk as well. I was interested in, it's nice to see, I hear the quote, FCR is still part of the conversation in IGHV mutated patients, even in 2021. We'll go to meetings where we're considered heretics if we mention FCR. Your thoughts on that from your just practice vantage point?
Yeah, I mean, I think so. I mean, we do have the restrictions of a lack of alternative funded options in that setting, but I actually don't feel that is necessarily limiting conversations in the clinic with patients with favorable risk disease and discussing the option of indefinite BTK inhibitor therapy, let's say if there is access available through private insurance or what have you, versus treatment with FCR. I think clearly the long-term outcomes and the potential for that, again, however you'd like to describe it, functional cure of CLL, long-term disease control, I think is important. I think patients place value on that. Yes, there's a need to consider long-term toxicities as well, and I think that's where perhaps when concern is raised, it's around the issue of secondary myeloid malignancies, and that 4 to 5% of patients with longer term follow-up. Again, I think it remains a relevant treatment option for low risk CLL, and time limited 6 months of therapy, and the hope for long-term disease control, I think is still remains an important outcome for patients as well.
And as we look at older patients where in good risk, I guess we should make clear, high-risk patients, they end up being about 60% plus of the patient population requiring therapy if we use mutational status in FISH, right? So in the minority of patients that are good risk over 65, obinutuzumab and chlorambucil has been our standard. I mean, do we need a novel agent in good risk patients?
Yeah, it's a great question. Do we need it?
Up front.
Yeah, I mean, it's an interesting way to frame the question. Do we need it? I think, I think the incorporation of novel agents into low-risk elderly comorbid patients, I think, does need to take some. There needs to be some caution. I mean, what are your goals? I think in that population, you would like a very effective therapy that is likely to induce prolonged remissions and to be well tolerated and hopefully cost effective. Chlorambucil plus obinutuzumab, I think, has been considered to be a well tolerated, effective regimen. Median PFS, based upon studies that we have available, is in the range of, let's say, 2.5 years, at which point, at some point after that, patients will develop an indication for second-line therapy, and you'll be into novel agent approaches in that setting. I think the novel agents of ibrutinib, let's just start with that, versus the time-limited Veno of CLL14, where you have 12 months venetoclax and obinutuzumab, followed by what appears to be potentially very long remissions. I mean, the PFS curves in that subset of patients at roughly 4 years, coming up on 5 years of follow-up, are obviously looking very, very positive. So I think that that there is the potential that a regimen like Veno really does make sense from the perspective of efficacy, tolerability, and potentially cost effectiveness. When you sort of look at that, I do think that chlorambucil obinutuzumab is still a very reasonable option for treatment. It also tends to be well tolerated. Obviously, there's going to be decisions that need to be made at a funding level in terms of whether or not there's a rationale for funding a novel agent in that population. I must admit, I think, I'm intrigued by the favorable tolerability of venetoclax, that 12 months and what appears to be deep and prolonged remissions. And so I think that's a very legitimate alternative to chlorambucil obinutuzumab.
Switching gears, BTK inhibitor intolerance. We have the most experience with ibrutinib. We've got a lot of experience with that. If a patient's in remission and in a patient who cannot tolerate the drug, what's your approach in that? Do you look at switching agents or will you observe them? So,
I mean, I think in most instances, a period of observation is actually important. I think you do want to so the scenario you presented with somebody who's in remission, so presumably meaning counts are okay and not a lot of related symptoms or concerns around adenopathy and organomegaly. But if that's the scenario, particularly, well, I think regardless of whether they've been treated for shorter or longer periods of time, again, I think that that second-line therapy really should await, more clinical evidence of symptomatic disease progression. I guess the question is, how do you is there anything different in the novel agent era around the timing of initiating therapy? And I guess the thing that comes up occasionally is, the timing of making a move to a venetoclax-based regimen and the concern around that ramp up in tumor lysis syndrome. Again, I must admit, I think my approach has typically been to monitor patients until such time as they develop symptomatic progressive disease, and to stratify accordingly, and then move on to next available, the next best treatment option, which in the case of BTK, true BTK intolerance, is often to move to a venetoclax-based approach. We do have some availability of moving to a more selective BTK inhibitor. Acalabrutinib is available to some patients with private insurance and is available to us compassionately. I have considered that and reviewed that with patients as well, about making a switch, sort of, in other words, maintaining the approach of their indefinite BTK inhibitor therapy and making the switch to acalabrutinib. There's, again, some limited data to support that many patients will tolerate that more favorably, particularly, I think, if it's, some of the non-BTK relevant toxicities. So I know I'm not maybe answering your question too directly, but I think it's, my approach has included consideration of switching to a more selective BTK inhibitor in some cases. Very often, though, it's been a period of observation, particularly the kind of toxicity that requires discontinuation. And once they become more symptomatic and progressive, to then, initiate them on appropriate next line therapy.
Last question. Combination therapy, BTK inhibitor with BCL2 inhibitor, venetoclax, really exciting data in terms of remission rates, and then MRD-directed therapy. When do you think we'll be able to actually have that in the clinic and we can give it to our patients?
So I think that the wide introduction of combination therapies like that is going to require patience and completion of comparative clinical trials that are really that have longer term follow-up, evaluating against our current standards of really what is BTK inhibitor monotherapy. So I think it could be some time before combination of a BTK inhibitor and a BCL2 inhibitor are going to be available to us in the clinic. I'm also not, I don't think there are trial opportunities, at least not currently in our environment, that are available to us, which I think is unfortunate. But there isn't, I don't think there's anything on the horizon from, again, some of the major cooperative group trials. So I think it will require, unfortunately, a little bit of patience before these are routinely available to us. That's my educated guess.
Graeme, listen, we appreciate very much your insights, Canadian context. It's been great. I want to thank everyone for attending the CLL session. I hope you enjoy the rest of the meeting.